the chance to discuss our ccRCC trial. This is a phase 2 open-label single-arm study of neoadjuvant zanzalintinib plus nivolumab in patients with locally advanced and/or inoperable clear cell renal cell carcinoma. These are my disclosures. And so a bit on background and rationale, as we've heard today, I think the role of VEGF TKIs in IO therapy in the perioperative setting remains to be defined. In the adjuvant setting, sunitinib showed disease-free survival benefit, but in the context of other negative VEGF TKI trials. In pembrolizumab, as we've just heard, showed DFS and OS benefit, but again, in the setting of other negative IO trials or ongoing IO trials. And then the neoadjuvant setting, some of these slides will look eerily similar, so I might skip over them a little bit. But there are studies looking at VEGF TKI monotherapy, IO monotherapy in combination. And so this table looks eerily similar, but what I want to highlight is, as was discussed, and again with cabozantinib that we just heard about, there's certainly response to VEGF TKI monotherapy. But that response is widely variable in terms of primary tumor reduction, overall response rate, likely due to the type of TKI, the time on TKI, right, from days to months. The inclusion criteria was some with localized only, some with locally advanced, and others including metastatic disease. And of course, these are very small pilot phase 2 trials. I also want to highlight that this is not really the case with neoadjuvant nivolumab. Although it was only given for 6 to 8 weeks, I'd be very interested to see the trial that was just presented with neoadjuvant pembro. But with nivolumab, we really did not see much tumor shrinkage in the neoadjuvant setting. I think what these trials did show is the feasibility and safety of utilizing these agents in the neoadjuvant setting with adverse events consistent with what's known and no major surgical delays or complications. And then this also looks very similar as the NeoAVAX trial, enrolling high-risk non-metastatic clear cell renal cell carcinoma patients and treating them with 12 weeks of avelumab and axitinib. And what I want to highlight is, as you know, Dr. Margulis highlighted, the overall response is 30%. When I look at that, I do wonder how much the IO is truly adding to the combination therapy, because that's not too different from VEGF TKI monotherapy. But if we look at the long-term follow-up, again, as Dr. Margulis highlighted, more patients with a response remain disease-free when compared to the overall cohort. So is the IO helping us in terms of kind of longer duration of response, right, and some of these long-term efficacies? And not in this trial deck, but there's actually other neoadjuvant VEGF TKI IO combinations that have read out recently. There's one with toripalimab plus axitinib, which is a PD-1 inhibitor. The overall response was actually 45%. There's another one with teslilizumab plus axitinib, and that one had an interim analysis of only 9 patients, but that one actually showed an overall response rate of 55%. And so I think these trials do demonstrate the efficacy, feasibility, and safety of the combination in the neoadjuvant setting. Again, eerily similar, which I guess is a good thing, that we all agree, right? These are the considerations in the neoadjuvant setting of the type of agents, optimal duration, optimal cohort, localized versus locally advanced, and what are our goals? One of the main ones, I think, is certainly tumor downsizing and downstaging, but also can we eradicate micrometastatic disease? And then to our urology surgeons, what are the perioperative and postoperative complications? So with these in mind, we designed the ccRCC trial, which is a little bit different in that we used a more novel zanzalintinib VEGF TKI in combination with nivolumab. These are pretty local advanced and or inoperable patients. And we used zanzalintinib because Dr. Tanner made my life easier because he already went through zanzalintinib earlier today. But it's a next generation VEGF TKI with a very short half-life, which is fantastic in the neoadjuvant setting. And we saw the pretty significant efficacy in Stellar-01, and Stellar-02 is ongoing with Zanza plus nivolumab, hence the combination that we've chosen for this trial. In terms of our ccRCC trial, this is a phase 2 single cohort design with adaptive approach. And this trial is currently not open, but is geared to open for accrual early next year. And so patients with clear cell renal cell carcinoma with or without sarcomatoid component who are locally advanced, defined as CT3, T4, and or inoperable. This is per surgeon discretion. So these patients could have very large tumors that are invading. They could have, decreased renal function to where you're trying to really do maximum nephron sparing, etc. And these patients can also have non-measurable small metastasis. And so that's defined as our patients that we see with a couple of lung nodules that's less than 1 centimeter or lymph nodes less than 15 millimeter or 1.5 centimeter. And so all patients will be treated with 12 weeks of zanzalintinib plus nivolumab. And our primary endpoint is overall response rate at 12 weeks. But this is where the adaptive design comes in. And so for patients who become operable, they will undergo surgery and then go on to receive standard of care adjuvant therapy, which we assume will be pembrolizumab. But for patients who are still not optimal surgical candidates, they can actually continue Zanza plus nivolumab for up to about a year. And during that time, they will get rescanned and see urology to determine eligibility for surgery. If at any point they become surgical candidate, they can then go on to get surgical resection and adjuvant therapy thereafter. Of course, any patient who progressed on therapy will then come off trial and go on to standard of care. And so I think this allows us to see kind of this new adjuvant approach in a much longer term, depending on patient response. These are the hypotheses. So again, our primary endpoint is overall response rate at 12 weeks, with key secondary endpoints being for patients who are deemed inoperable, how many of those patients became operable, and of course, safety. We're also interested in, for resected patients, their disease-free survival, surgical outcomes, pathologic complete response, tumor necrosis, and rate of patients who actually received adjuvant therapy. As well as overall survival. And of course, we have some robust correlatives in the making. We've already went through all the key eligibility criteria, so I will not belabor those here. In terms of implementation, this is going to be a multi-site IIT implemented through the Hoosier Cancer Research Network, with UT Southwestern being the lead site. This is actually a figure that I got from urology colleagues, just looking at how much kidney cancer surgeries we've done and the increase. And so we are looking for additional potential sites with high surgical volume, and listed here are sites who are interested, and we're hoping to open this at about 5 to 7 sites. And so in summary, I think optimal timing and therapy combinations in the perioperative setting remains to be defined. The ccRCC trial will evaluate Zanza plus nivolumab in neoadjuvant setting with pretty locally advanced disease patients, again, able to treat for up to 1 year. And I think results from ccRCC, the lenvatinib pembro trial by Dr. Margulis, other ones that were mentioned, and correlatives can shed additional light on the role of VEGF TKI IO in the perioperative setting. So with that, I would like to thank you for your time and start discussion.